Good morning. Today we are going to talk about epilepsy and pharmacotherapy of anti-epileptic drugs. Epilepsy is basically a recurrent paroxysmal seizures or convulsions. So now we have two more new terms: seizures, which is basically abnormal repetitive firing of neurons and is mainly sensorial, whereas convulsions is majorly motor component. So with this background, let us go into anti-epileptics. There are many types of epilepsies, which mainly include, of this we grossly divide them into either a focal onset or generalized onset. With respect to focal onset, a small set, let us consider this as our brain, and a small set of neurons will be involved, whereas in generalized onset, if this is our brain, your whole brain will be involved majority of the times. Clear? Now with this background, let us go into anti-epileptics proper. Anti-epileptics. So, before starting anti-epileptics, let us understand the pathophysiology of epilepsy. As discussed earlier, what we understood is there is abnormal firing of neurons. What I mean by firing of neurons? Abnormal excitation of neurons. So, for a neuron to be excited, we need certain ions and certain neurotransmitters. Consider this as my neuron and this is my other neuron. Now, what are the most important ions which are responsible for activation or firing of neurons is sodium ion and calcium ion, whereas the excitatory neurotransmitter mainly includes glutamate, whereas the ions which primarily cause inhibitory action is either potassium and the neurotransmitter responsible is GABA. In the case of epilepsy, there is either increase in the excitatory neurons or reduction in the inhibitory neurons, inhibitory neurotransmitters. So, our anti-epileptics primary goal is either to attain that balance, either it has to reduce the excitatory neurotransmitter or excitatory ions or increase my inhibitory neurotransmitters, increase my inhibitory neurotransmitter or inhibitory ions. So what I mean by this is anti-epileptics should either reduce or block sodium ions, calcium ions and glutamatergic receptors or glutamate receptors, as well as they should either increase GABA or increase the movement of potassium ions. Now, with this background, based on the mechanism of action, let us classify our anti-epileptics. First probable mechanism is blockage of sodium ion channels. See, blockage of sodium ion channels is relatively a tougher thing. So what we usually do is we prolong the inactive phase of sodium channels. What do I mean by inactive phase? Usually, so any ion channel exists in three phases. This is my resting phase. This is my sodium channel. Okay. Now, a sodium channel has two gates. Okay, when both are closed, we call it as resting phase, during which movement of ions through the ion channel is not possible. Then comes active phase, where both the gates are open so that movement of ion is possible. This we call it as active phase. Now comes the third phase of inactive phase, where the ion channels extracellular gate will be open but the intracellular gate will be closed, so that though ions try to come, they bounce back. We call this as inactive phase. Usually, sodium ions stay in resting phase. Under appropriate stimulus, it goes into active phase, which later turns into inactive phase and comes back to resting state slowly. Now, what do my anti-epileptic channels do is they prolong the inactive phase of sodium channels, so that time taken from an active sodium ion to the resting sodium channel will be increased, during which no extra impulse or no new impulse can be transmitted. This property is also called as membrane stabilizing property. Now, what are the drugs which can block the sodium channels or prolong the inactive phase of sodium channels? These drugs include phenytoin as well as phosphenytoin. Then comes our carbamazepine, sodium valproate, and certain newer drugs like your lamotrigine, topiramate also act through this. Now, this is about our first one. So, we have finished our sodium. Now, let us talk about calcium. With respect to calcium, our main thing is they should block calcium channels. Calcium channels which are present in our brain are mainly restricted themselves to T-type calcium channels or thalamus type of calcium channels. So, the drugs which mainly modulate T-type calcium channels or inactive or block or inhibit T-type calcium channels include ethosuximide, Valproate. Now, let us talk about with this, we have finished our second one also. Now, let us talk about glutamate, which is our excitatory neurotransmitter. Our excitatory neurotransmitter, glutamate, acts through two receptors, AMPA receptors, AMPA, as well as NMDA receptors. Drugs which block AMPA receptor include perampanel and drugs as well as topiramate can also act through AMPA. There are certain drugs which primarily inhibit glutamate release, mainly by acting through SV2A, which is a synaptic vesicular protein, which mainly acts through calcium, which activation is mainly through calcium. This will be blocked, and the drug which is responsible for this is levetiracetam. Now, we have finished all our excitatory is finished. Now, let us talk about inhibitory. Inhibitory neurotransmitter is GABA. We are more bothered about neurotransmitter rather than the ion. So, GABA. With respect to GABA, there are many methods. One such method is GABA receptor modulators. One such drug which increases the frequency of GABA mediated opening and chloride channel entry into the cell is Frequency is mainly benzodiazepines. Whereas in the same way, which increases the duration of GABA channel opening and increases the chloride entry into the cell is barbiturates. And the other one is, this is our first receptor modulator. Then comes our second one, either drugs that reduce GABA metabolism. GABA is primarily metabolized by transaminase. So, drugs that inhibit transaminase enzyme include valproate. Includes valproate as well as vigabatrin. These two drugs inhibit GABA transaminase, so inhibit GABA metabolism. So that GABA is present for a longer duration, my inhibitory neurotransmitter is present for a longer duration. There is one specific method for GABA. What usually happens, in fact, for majority of our neurotransmitters is, whenever GABA is released, this GABA is usually reuptaken into glial cells. This GABA, whatever is released and unused, will be reuptaken into glial cells. So, drugs which inhibit this reuptake or GABA reuptake inhibitors. Reuptake inhibitor is tiagabine. It mainly inhibits GAT1, GABA transporter 1. Clear? With this, we have finished the mechanism of action and mechanism of action based classification of our anti-epileptic drugs. With this background, let us go into individual drugs. We are not going to discuss all the drugs. Phenytoin, valproate, carbamazepine is what we are going to talk more. With respect to phenytoin, it is an age-old drug. Basically, with respect to any drug, in fact, we'll talk with mechanism of action, special pharmacokinetic features, uses, and adverse effects. Clear? So, with respect to mechanism of action, most important mechanism of action is it prolongs the inactive phase of sodium channels. Clear? So, it acts as a membrane stabilizer. This is one most important action, and this is the most important action, as well as because of this it attains first thing, obviously, membrane stabilizer. Second one is reduces intracellular accumulation of sodium. Third one is it inhibits high frequency discharges of neurons. Now, let us talk about special pharmacokinetic features of phenytoin. Most important is it's a narrow therapeutic index drug. So, the concentration must be very cautiously maintained and should be monitored using therapeutic drug monitoring. And the second most important thing is it follows a mixed order kinetics. Why is it so? It is usually metabolized by CYP2C9, CYP2C9 and 19. The CYP2C9 is in very lower concentrations, and when phenytoin is given in appropriate dose, the metabolism follows first order. Later, in higher doses, it follows zero order kinetics. These are the specific features of your special pharmacokinetic features of your phenytoin. Now, let us talk about uses. One most important use of phenytoin is obviously your epilepsies. Be it focal epilepsy, be it GTCS, whatnot. For everything, phenytoin is used. Then, because of its membrane stabilizing property, phenytoin can also be used in digoxin-induced arrhythmias. As well as previously or just as an add-on drug, we can use them in trigeminal neuralgia. Now we will talk about adverse effects. Before going into adverse effects, I want you to understand that phenytoin cannot be given IV bolus. If at all has to be given, must be given only by infusion. If given by bolus, it causes severe thrombophlebitis. To overcome this, in a case of status thrombophlebitis, so to overcome this, we have developed a water-soluble form of phenytoin, and we labeled it as phosphenytoin. This phosphenytoin can be easily handled by intravenous route. This is my first adverse effect. Usually, adverse effects of phenytoin, you will read under two subheadings. One is toxic effects, where the dose is high, as well as chronic effects, where when you use your phenytoin for longer durations, patient ends up in these adverse effects. With respect to toxic effects, cerebral toxicity, cerebellar toxicity, and cardiovascular toxicity. These three are the most important. With respect to cerebral toxicity, hallucinations and all can occur. With respect to cerebellar toxicity, nystagmus, ataxia can happen. And with respect to cardiovascular toxicity, it itself induces arrhythmias, mainly bradyarrhythmias. Now, on chronic usage of phenytoin, it causes gum hypertrophy, mainly because of mainly because of collagen hyperproliferation, and second one is hirsutism. Then your hypersensitivity, it also causes megaloblastic anemia, as well as it causes osteomalacia. These are osteomalacia. This is because of vitamin D absorption hindrance, and this is because of folate absorption hindrance. And finally, in a case of pregnancy, if a patient takes phenytoin, the fetus will end up in fetal Hydantoin syndrome. The characteristic feature of fetal Hydantoin syndrome is cleft palate. I think with this we have finished phenytoin. Now we will talk about carbamazepine. See, carbamazepine is also an important 5 marks question for you. Oh, sorry. Carbamazepine. Mechanism of action, it is similar to, with respect to mechanism of action of carbamazepine, it is similar to phenytoin. That is, it prolongs the inactive phase of sodium channels. And now let us talk about uses. One most important use of carbamazepine is it can be used in all sort of epilepsies, so focal seizures, GTCS, everything, as well as this is first drug of choice in case of trigeminal neuralgia, as well as this drug can be used in bipolar disorder. Now, the adverse effects. Special pharmacokinetic features. Most important PK features is it's an auto-inducer of its own metabolism. So, when carbamazepine is used for prolonged duration, the dose must be increased. Now, with respect to adverse effects, most important adverse effect is it causes aplastic anemia and agranulocytosis. Anemia and agranulocytosis. It is known to cause cerebellar toxicities. So nystagmus, ataxia and all can be seen. Then it causes SIADH, syndrome of inappropriate antidiuretic hormone secretion, where there will be increased ADH, and this increased ADH results in hyponatremia, mainly dilutional in origin, as well as water retention. This is also teratogenic in nature. With this, we will conclude carbamazepine also. Now, we will talk about valproate. Valproate is a very important 5 marks question for you as well as essay. Valproate is considered as a broad spectrum anti-epileptic agent. What I mean by this is, if the clinician is not sure which sort of epilepsy the patient is suffering from, then we can directly add valproate. With respect to mechanism of action, it has all the possible mechanisms. What I mean by that is, obviously it blocks P-type calcium channels. Second one, block calcium channel block, as well as it prolongs the inactive phase of sodium channel. As well as it acts through, it reduces glutamate by blocking NMDA, and also it acts through GABA. It increases GABA mainly by 2. It inhibits GABA transaminase, which is an enzyme used for the metabolism of GABA, as well as it increases glutamate decarboxylase enzyme, which is responsible for synthesis of GABA from glutamate. Because of its wide spectrum of action, this is active against all sort of epilepsies. So, with respect to uses, this is used in all type of epilepsies. So, all epilepsies you'll treat. And then it is also a mood stabilizer. It is also used in the prophylaxis of migraine. It is also used for the treatment of panic disorders and can also be used in some neuralgias as an add-on drug. Clear? Now, with respect to adverse effects, something what we have to bother, most importantly, it causes weight gain, alopecia, anorexia, nausea, vomiting, diarrhea, hypersensitivity reactions. Along with this, it also causes thrombocytopenia, because of which there will be a increased incidence of ecchymosis and epistaxis. It also causes fulminant hepatitis. For this reason only, every patient who is on valproate will be regularly monitored with liver function tests, and this itself is highly teratogenic. So, this must not be given to pregnant females. It causes spina bifida in the fetus. With this, we have even finished our Valproate. As such, 5 marks questions in epilepsy is finished. But we need to understand newer anti-epileptic drugs are more increasingly used. So, we will just go through the mechanism of actions of newer anti-epileptics. Let us put it as newer anti-epileptics. So first one is lamotrigine. See, lamotrigine is considered as safest anti-epileptic agent anywhere, and is one of the broad spectrum anti-epileptic. It mainly acts through sodium channel prolongation of inactive phase. Fine, and is broad spectrum. Why I am talking about broad spectrum? Because it can be used in all sort of epilepsies and is safe. So, can be used even in pregnancies. Clear? Then, gabapentin, pregabalin group of drugs. We all thought that gabapentin, pregabalin is gabapentin, pregabalin. They mainly modulate GABA system. But usually, these drugs act through alpha 2 delta 1 channel and reduce calcium entry and inhibit glutamate release. One most important point regarding this is these are drugs of choice in all neuralgias or neuropathic pains. Then comes our third one, levetiracetam. Levetiracetam is also recently approved and is very good drug. Levetiracetam, it mainly acts through SV2A. It is a vesicular protein which is responsible for glutamate release. By inhibiting SV2A protein, it reduces glutamate release. This is also considered as a broad spectrum anti-epileptic agent. Then comes our perampanel. Name itself has perampanel. So it is basically a AMPA antagonist. AMPA is receptor for glutamate. Then comes our topiramate. See, topiramate has found lot of importance these days, mainly because topiramate acts through many actions, that is your sodium channel prolongation of inactivation phase of sodium channels, increases GABA as well as reduces glutamate by blocking AMPA, and along with all these specialties, topiramate is also a broad spectrum and one advantage is it can also be used in migraine prophylaxis. Clear? Now let us go through the names of others like zonisamide, which also has same like your phenytoin like action. Vigabatrin, rarely used now, Vigabatrin, mainly because it causes visual field defects. This is with respect to pharmacology of the drugs. Now let us go into pharmacotherapeutics. What I mean by that is how do we treat a case of epilepsy? First episode of anything, or either of seizure or your convulsion, anything need not be treated, but efficient workup must be done to find out the cause. Then epilepsy with pregnancy. Usually if the patient is on any sort of older anti-epileptic agents like phenytoin, valproate, anything, slowly the dose must be reduced, and newer anti-epileptic, mainly lamotrigine, is introduced. Even the patient is on lamotrigine is introduced these days, but not directly replacing. We will slowly taper the previous anti-epileptic agent, and we also add folic acid in very high doses as well as vitamin K for the mother. This is with respect to epilepsy with pregnancy. Now let us talk about febrile seizures. where pediatric age group, because of increased temperature, patient will end up with fever and epilepsy. Obviously, paracetamol will be given, diazepam is preferred in this. Clear? Now, let us talk about status epilepticus. See, status definition varies in a variety of ways. With respect to our books, if a patient turns up with epilepsy or with an episode of convulsions for more than 30 minutes, then we label the patient as status epilepticus. How do we treat? Obviously, the first drug of choice is lorazepam. Lorazepam is a benzodiazepine group of drugs. It mainly increases the frequency of GABA chloride channel opening so that more chloride ion enter into the neuron and there will be less firing. And lorazepam is preferred over rest all drugs, mainly over diazepam primarily because it causes less thrombophlebitis and there will be less redistribution. Rapid onset of action. Lorazepam belongs to benzodiazepine group of drugs and it mainly increases the frequency of GABA chloride channel opening. If lorazepam is not available, then we can go for diazepam. Lorazepam is given at a dose of 4 milligrams or 0.1 milligram per kg body weight. And then if your symptoms are not reduced, your convulsions are not reduced with diazepam alone, we usually add phenytoin. Phenytoin is a water-soluble congener of phenytoin and is given by IV bolus, followed by phenobarbital. Even if seizures don't control, convulsions don't control with phenytoin, then we will add phenobarbital. Phenobarbital is a barbiturate group of drugs, rarely be used these days except for status. There is no approved indication for phenobarbital. If even with phenobarbital the patient did not have control of convulsions, then we will add midazolam, thiopentone, or propofol. Obviously, along with all these, most important thing is general measures, which include maintaining of vitals, temperature, pulse rate, blood pressure, respiratory rate, and glucose levels. Now, we will talk about usually for any epilepsy, treatment of choice, first line will be Valproate. And if the patient is affordable, we can happily add either topiramate or lamotrigine or levetiracetam. With this, I'll conclude our class. Thank you for patient listening.